MR-guided focused ultrasound of the dorsal root ganglion for the treatment of low back pain. Preclinical study in a peripheral nerve injury model. Chronic low back pain is often a diagnostic and management dilemma due to multiple potential pain sources with both biomechanical and inflammatory mechanisms. Non-invasive treatments with systemic analgesic drugs such as opioids often fail due to their off-target toxicity, development of tolerance, and abuse potential. Given the potential risks and long-term complications, highly invasive surgery is not an appropriate solution for many suffering from low back pain. Here, we are investigating MR-guided focused ultrasound of the dorsal root ganglion, as it could provide a non-pharmacological and non-invasive alternative. The dorsal root ganglion, or DRG, is a cluster of pseudo-unipolar neurons adjacent to the spinal cord that carry all sensory signals from the peripheral nervous system to the central nervous system. Neurons in the DRG not only carry sensory signals, including pain and temperature, they also play a role in pain modulation. Studies using electrical stimulation and thermal radiofrequency ablation of the DRG have shown viable short-term success in patients and animal models. Therefore, targeting the lumbar DRGs with MR-guided focused ultrasound has good promise for treating low back pain. There are several postulated mechanisms through which focused ultrasound might exert its analgesic effects. Localized tissue heating causes thermal damage to unmyelinated nociceptive fibers present close to the pain target. Mechanical effects on the neuronal membrane activate stretch-sensitive ion channels and create membrane defects that alter membrane potential, which then lead to changes in neuronal excitability, action potential propagation, nerve function, and pain perception. In our study, we developed a neuritis pain model in pigs, which mimics neuropathic pain. Peripheral nerve injury was induced by surgical exposure of the common peroneal nerve, followed by loose litigation with silk suture soaked in complete Freund's adjuvant and inflammatory agent. After post-surgical recovery, the animals underwent quantitative sensory testing. At the end of the study, the nerve was excised for histological assessment. The pigs were trained to stand in a testing arena equipped with cameras and microphones and underwent weekly quantitative sensory testing. We used a porcine pain scale that uses vocalization and facial expression as quantifiable measures of a supraspinal pain response. This scale mimics techniques used in nonverbal humans who cannot self-report. The test we performed included thermal pain threshold for heat and cold stimuli, mechanical detection thresholds for touch and vibration, and mechanical pain sensitivity with single and repetitive pinpricks. In this presentation, we are only reporting results with a heat pain threshold. We used a 650 kHz, 256 element phased array transducer on a stereotactic positioning system for the MR-guided focused ultrasound experiments. Imaging was performed on the 3T Siemens scanner. We performed two different experiments. 2 animals received focused ultrasound treatment with continuous wave ultrasound. 2 animals first underwent neuritis surgery, followed by focused ultrasound with pulsed sonications with a 50% duty cycle and a pulse duration of 13 milliseconds. The goal was to treat lumbar levels 1 through 5. Please note that pigs can have 5 to 7 lumbar vertebrae, but the lowest level is not accessible with focused ultrasound due to obstruction from the iliac crest. We performed real-time treatment monitoring during each sonication to verify the target location and measure the temperature at the target and surrounding tissues. For better visualization of the heating, the 3D temperature volume is reformatted and overlaid on the high-resolution T2-weighted anatomical image. DRGs were easily localized, and due to the large spinous processes in pigs compared to humans, direct targeting was hindered and required adjustment of the focus to the proximal spinal nerve root. Temperature estimation worked well in continuous sonications. In the longer duration pulse sonications, MR imaging exhibited a temperature drift and required correction in post-processing. Post-treatment imaging was performed at the end of the focused ultrasound procedure. None of the animals showed pain or any motor deficits during standard veterinary assessments. Post-treatment imaging shows T2 hyperintensity and peripheral enhancement with central non-enhancement in the left lateral vertebral body, reflecting edema and inflammation. Central non-enhancement was felt to be necrosis. Images obtained 7 weeks after focused ultrasound treatment show decreased marrow edema and decreased area of necrosis. Residual mild edema is seen in the left perifacet soft tissues. Of the different pain thresholds tested, the heat pain threshold showed the largest change. In the animals that received high temperature ablations, pain scored to the heat pain threshold increased over baseline directly after treatment and remained elevated for 2 weeks before returning to baseline. In the nerve injury model, pain scores increased after peripheral nerve injury in weeks 2 to 4, and then decreased for approximately 4 weeks after treatment. There were no changes in pain score on the contralateral side. We performed histological assessment after euthanasia. The left image shows H&E staining of the peroneal nerve near the ligation site. The nerve is surrounded by inflammatory cells, seen in purple, which are not present in the normal nerve and confirm the development of the neuritis. The images show a cross-section through the L2 vertebra at the level of the DRGs of an animal treated with continuous wave ultrasound and 3-week survival. So this is not one of the animals that received the 6 to 8 weeks of QST follow-up, but it was treated with the same focused ultrasound parameters. Histology processing appears to be more an art than a science, and we did not get good histological sections in all animals. The left and right side were processed in separate cassettes, so the slides don't line up perfectly. The green dotted line shows the approximate beam path and focal spot of the focused ultrasound transducer. The blue line shows the approximate area of thermally induced tissue damage or tissue changes, which correlated well with the area of damage seen on MR imaging. Zooming into the area of damage, we can see the area of osseous changes and coagulative necrosis in the muscle. Looking closer at the DRG, there's thermal damage with pycnosis of the cells seen in the lower part, but cell structure appears normal in the other parts compared to the normal DRG. Because the DRG lies partially behind the lamina, it is more shielded from the focused ultrasound. When we look at the dorsal ramus of the spinal nerve, which is not protected by bone, we can see very disorganized nerve cells with crinkled perineurium and not the organized linear structure seen in the untreated side. In summary, we demonstrated a peripheral nerve injury large animal model that produced neuropathic pain. QST outcome metrics parallel highly quantitative clinical assessments of neuropathic pain. They are sensitive indicators of pain in a large animal model and are clinically translatable. We have shown that it is possible to precisely target the DRG and spinal nerve with MR-guided focused ultrasound without causing motor deficits in the treated animals. Pain assessed with QST returned to baseline within 2 weeks in animals with high temperature ablation, demonstrating safety of the procedure. Neuritis animals showed the expected increase in pain after peripheral nerve injury that was ameliorated for 4 weeks following MR-guided focused ultrasound treatment. Histology confirmed successful targeting of the DRG. We would like to acknowledge our funding sources and thank you for your attention.